This is QD Clinic. Hi, I'm Jack Cush with Room Now. QD Clinic is brought to you by BMS, Hard Decisions in RA. Today's case is RA and breast cancer. This always gets people a little squeamish and squirrely. 42-year-old woman, previously diagnosed by me as having rheumatoid arthritis about 7 or 8 years ago. Returns to me after she's been gone 2 years. She had a baby about, so she's 42 now, had a baby about 5-6 years ago. Successful pregnancy, that all went well. She did well postpartum on, I think, just methotrexate is what she was taking. In the past, she was treated with methotrexate and a TNF inhibitor, and that's okay. That went fine. And then 2 years ago, she came down with breast cancer. And so roughly around the age of 40. She had bilateral mastectomy. She was estrogen receptor positive. She received treatment. She stopped her RA medicines, fell off the rheumatologist map and schedule, was managed by the oncologist with paclitaxel, doxorubicin, cyclophosphamide, even had radiation therapy for 5 weeks. At the time, she was on abatacept and methotrexate, and that was held. Post chemo, her oncologist put her back on methotrexate. She was doing well, but now she's not doing well. So she comes to see us with the baby's fine. She's fine. You know, she's had some reconstructive surgery. She's only on methotrexate 6 pills once a week. And the question is, what are we going to do for her current complaints of polyarthritis in the MCPs, PIPs, and knees? In the past, she was seropositive for RF and CCP. She previously had taken certolizumab and etanercept and abatacept. Now she's just on methotrexate, as I said, 15 milligrams a week with folate. And she's having pains. On exam, she has no deformities. She has 9 tender joints, 2 swollen joints. Her recent labs look good. Sed rate and CRP are normal. And the question is, what are you going to do? Oh, the other thing is, you know, she's taking fish oil and folic acid, Paxil, and she's on letrozole or Femara for hormonal therapy post breast cancer. So the questions at hand are, could that aromatase inhibitor, estrogen-based therapy, be causing her joint pain? Second, she's got a history of breast cancer. It's recent. She's not yet totally out of the woods. Do I need to be careful? Can I put her on a biologic? What would you do? What would I do? These are all easy issues. So when you see her, number one, you make sure she's sleeping fine, that she doesn't have tender points to indicate worry and poor sleep and fibromyalgia and polyarthralgia from that. Number two, the aromatase inhibitor related pain, a very common phenomenon with both tamoxifen and this drug letrozole, which is often used after tamoxifen or after tamoxifen fails. The incidence rate on people taking aromatase inhibitors is like 30 to 50%. And I think it's about a third. But they get everything from mainly arthralgia, sometimes tenosynovitis. They generally don't have any swelling from this. Often when they're evaluated, they're found other causes of joint pain like osteoarthritis or carpal tunnel or fibromyalgia. But again, they do get joint pain so much so that if you stop the aromatase inhibitor, it goes away, right? So in this case, there is no great therapy for that. And mainly because we don't really know what the etiology of it is. In talking to a number of people, the companies who make those products, the oncologists, if there's anything that might be associated with this, it is vitamin D deficiency. which I'm not a big fan of, by the way. I'm not a big believer that vitamin D causes all problems human, and then all problems human are fixed by giving vitamin D. But in these people, check the vitamin D and then optimize it in an aggressive manner. And some of those people do get better. That's my only trick, if you will. Now you got to get on to treating her. She has active disease. Check her labs. Know that you can give her. What can you give her? Well, the ACR, I don't necessarily believe in all their guidelines on RA treatment, but they got this right going back to 2015 and also in the current guidelines. And that is to say, any RA patient who has a solid tumor should be treated as, and they have a cancer, should be treated as if they don't have the cancer. Meaning, having a solid tumor, lung cancer, prostate cancer, breast cancer, pancreatic cancer, hair, all kinds of, crazy things, cholangiocarcinoma, you name it, doesn't really matter. Gastric cancer, cancers with good prognosis, cancer with bad prognosis. It doesn't matter. You treat with the best drug that you have at your disposal. That does not change the odds of them dying, getting recurrence, or having worsening of their cancer if it's still active, right? And that's a very clear decision by the guidelines people and by the data and by me. So what am I going to give this woman? Whatever the heck I want. In this case, she says she did very well on abatacept. I'm going to put her back on abatacept. She wants to take it sub-Q, so she doesn't have to get the infusions. We're going to give her sub-Q weekly, and she'll be well in a few weeks. So she gets vitamin D assessments, vitamin D therapy, sub-Q abatacept, and she continues her methotrexate. This is the smart way to manage people with solid tumors who also happen to have rheumatoid arthritis. Tune in for more QD Clinics.